For those of you who have not seen me before, my name is Brendan McGreevy, otherwise known as Nerdy B PT. I'm a residency trained physical therapist. I'm also orthopedic board certified as well, and I've been in the game for 9.5 years. Talked on quite a few different topics in the orthopedic sports world, as well as just general wellness, and these are my passions. So today what I'm going to be talking about is sleep. Today's presentation, don't sleep on sleep, real world tools for better outcomes. So we're going to review some screening approaches, coaching, and interventions that we can apply in the clinic on the day-to-day. So let's set our course for today's quest. What I want you all to walk away with by the end of the session is, first we'll look at some of the numbers behind sleep. Then we're going to define the physical therapist's role in all of this, because the APTA has made it pretty darn clear that screening, education, collaboration around sleep are part of our professional scope, for sure, and we'll review that. Next, we're going to talk about how to screen smarter using validated tools and questions that you can integrate right into your eval without adding any more time to your day. What we're going to look at next from there is we're going to look at behavior change. We're going to look at how do we go beyond sleep hygiene tips, the generic day-to-day questions we might ask, and start coaching in a way that actually helps patients follow through. Following, we'll explore how to provide rest as medicine, translating evidence from cognitive behavioral therapy for insomnia and exercise science into the PT plan of care. And then we're going to get practical. How do we document efficiently? We'll look at some example SmartPhrases that you might integrate into Epic or your other EMRs to streamline the education and communication with your team that you're working with. And then, of course, at the end, we're going to kind of put it all together and come up with a game plan in regard to how does this fit in the day-to-day in a real-life scenario. So that's kind of our roadmap. And for the next about an hour or so, we're going to piece all this together. And by the end of it, you're going to have some practical evidence-based tools to add straight to your clinical utility belt and just be a PT superhero for everybody. All right, so let's start with, again, a few numbers that really kind of brings some perspective to sleep. So first off, 1 in 3 adults in the U.S. get less than 7 hours of sleep per night. And according to the CDC, that's a deficit of sleep over time. So it means that basically every third person who walks into the clinic is probably under-rested before they even start the session. So kind of keeping some of that in mind. Somewhere between 50 and 70 million Americans live with chronic sleep or wake disorders, and believe it or not, that's actually on par with the number of people living with things like diabetes or hypertension. So it's quite an impressive number. Yet, where we may take vitals and we'll do chart reviews and med screens, like this sleep may not be something that we're regularly screening for how prevalent it is as far as quality goes. So, of those 50 to 70 million Americans, about 10 to 15% meet full criteria for an insomnia disorder, meaning persistent trouble falling or staying asleep at least 3 nights a week for 3 months or longer. Even further, what's pretty crazy, I think, is that upwards of 80 to 90% of these folks go completely undiagnosed. So most people struggling with poor sleep never actually receive that formal support that they need, and we may be the first people who identify it, but we certainly have the opportunity to. All right, so as far as some overlap with particular patient populations that we see prevalently, upwards of 40 to 70% of people with chronic pain also have insomnia or significant sleep disturbance otherwise. And this is no news to any of us who have been working probably more than a day or beyond our clinical rotations from school. that we know that those in chronic pain have difficulty sleep, and that there's a bidirectional relationship with poor sleep quality and turning up the volume on intensity and ease of pain and other symptomology. So we treat pain all day, and we often skip the thing that either can amplify it again or alleviate it, and that's sleep. Like, that's how people get better sleep. Let's assess this thing and be able to talk about it intelligently. So even when patients do have, chronic insomnia, again, just we're looking at only 12% getting a formal diagnosis, which again is pretty crazy. So the vast majority of these cases are just flying under the radar. And even further into another disorder that we all are familiar with, obstructive sleep apnea, or OSA, is incredibly common. Estimates vary globally, but most data show that over 80% of adults with moderate to severe OSA remain undiagnosed. So another high prevalence as far as those folks who aren't formally diagnosed or being treated, where we can be that first person to help, highlight this as an issue and help these folks out. So when your patient tells you they're always tired, maybe their spouse comes in, or they tell you themselves that they're a snorer, or that they need a nap after work, or a daily nap for that case, those aren't just, throwaway comments just to say oh yeah, I get tired too, or, yeah, I love naps, or, whatever it might be. These are indicators to say, hey, maybe we should ask some curious questions. So, all this adds up to this, national burden when we think about how prevalent these insomnia and OSA cases are in regard to work productivity, how sleep deficits impede our health in other ways. And so there's some data that suggests that upwards of $411 billion with a B dollars per year in lost productivity, increased medical costs, downstream health impacts from sleep quality deficits, which is just insane. So, another step to go along with that, this is more than we spend annually on cardiovascular disease, which just seems nutty. So, sleep, super important to think about and consider seriously. So, given how big these numbers are, how many of us are actually asking about sleep during an evaluation beyond the general, hey, does your pain or does your symptoms impact your sleep? Yes. Okay. How so? Oh, you miss a few nights. There's a few nights where you miss out on 2 to 3 hours. Okay, I'm going to document that. And then conversation stops. I see that far too often. So now transitioning into, this is great and all, but as a physical therapist, what's my role in this? Where's my scope start and end? So the APTA defines our scope as promoting health and wellness through movement, function, and participation. And since we know that sleep impacts all three, it's literally the body's recovery system. So this is our wheelhouse. So, if we're going to be the experts in recovery, then sleep is right in our lane. So we got to really think of it that way. Sleep quality is going to predict outcomes across nearly every domain we measure as well. When we think of pain, fatigue, mood, performance, all these factors that we think about otherwise, sleep impacts these. When a patient isn't progressing as expected, sleep could be one of our missing variables that we're perhaps not considering seriously. Screening for sleep disturbances is considered within the scope of PT practice. We're not diagnosing, of course, but we're identifying red flags and referring appropriately, just like we would screen for depression, fall risk, cardiac symptoms. We can, and most definitely should, be screening for sleep. So patient education around sleep, hygiene, pacing, recovery, it's all super important behavior. This is a super important behavior change lever that we can use over and over again to help impact someone's life in a positive manner as physical therapists. We're already educating on things like load management, exercise dosage, and really sleep is just another dosage variable to optimize for individuals. So if a screen's, again, is kind of suggesting sleep apnea, maybe we're screening depression, or we're screening for chronic insomnia or anything else, that's our cue to build up the team. That's our cue to collaborate. Not to treat necessarily outside of our lane, but to connect patients with the sleep medicine professionals, the psychologists, if that's warranted, getting back with their primary care while reinforcing recovery strategies on our end along the way. So again, according to the APTA's role of physical therapists in sleep health statement, addressing sleep falls well under our umbrella of promoting wellness, preventing disease, and optimizing performance across the lifespan. So as PTs, we're not just treating the daytime body. We're influencing how it restores itself at night. And the next step is knowing how to screen smarter for it. So let's transition to that exactly now. So screening smarter. Now that we know why sleep matters, let's talk about how we can actually screen for it in a way that's fast, validated, and fits inside a real-world PT evaluation. So to start with, a common screening that we can utilize is the Insomnia Severity Index. This is a very short, just 7 questions, and it's validated in rehab populations, so perfect for us. It gives us a quick snapshot of how much insomnia is interfering with daily life for an individual. And, I kind of think of an instance where, I would use the ISI, if you will, if I hear a patient kind of mention, I just can't fall asleep at night. I have a hard time. When we look back and reflect on the score, when we add it all up, if we look at a 15 or higher, this kind of should send a flag up for us and start thinking that this person may likely have clinical levels of insomnia, and we should refer those folks out. Moving along, there's the Pittsburgh Sleep Quality Index. This measures overall sleep quality and not just insomnia. This looks over different domains such as duration, sleep latency, sleep efficiency, and it's a bit longer, but it definitely encompasses a good breadth of different qualities of sleep. It's just 19 items. We look at it as kind of the gold standard for looking a little bit deeper into someone's sleep experience. And when we look at some of the studies here, a total score of 5 usually indicates someone has poorer sleep quality, and we may need to refer out to the appropriate providers for that. Moving on, we have the Epworth Sleepiness Scale. This screens for daytime sleepiness. It can be especially useful when you suspect OSA or fatigue-related issues. So, we kind of ask how likely are folks, to snooze off during common situations like watching television, sitting in traffic. We might take this out of our clinical tool belt if a patient comes in and they say, honestly, I'm just exhausted all day. I haven't worked on any of the exercises you gave me because I'm just so tired by the end of the day, even the middle of the day. We might look into, does this person have some sort of sleep disruption that is persevering into the middle of the day? If one of our patients scores a 10 or above on this measure in particular, that's suggestive of excessive sleepiness, and we should investigate further. Lastly, a very easy one that we can utilize in our day-to-day is the stop bang. And this is a super easy go-to for quick screening for sleep apnea. It's just 8 questions, yes or no. We ask about snoring, tiredness, observed apneas. We look at their blood pressure, BMI, other sorts of measures. And, if we're thinking that someone's airway is obstructed or has some sort of like cardiopulmonary overlaps, we may, utilize this for those type of populations. For this test in particular, a 3 or more, in particular a 5, depending on where you're looking, are going to be indicative of likely OSA. So just to refer these again, if our screen suggests moderate to severe insomnia, high stop bang, or daytime sleepiness affecting safety, that's a referral red flag for sure. Now, we don't want to diagnose these. We can kind of educate on this is what these findings suggest, but we want to direct them towards their primary care, sleep medicine specialist, behavioral health specialist for further workup, all the while providing them education on how to improve their sleep quality, again, without lending out a formal diagnosis. So sleep behavior change follows many of the same kind of stages of change that we recognize for things like exercise adherence. So if we go back to, and a lot of folks are familiar with the 5 stages of change, and for those of you who want, I'm going to kind of break this down in the way of sleep. So in the pre-contemplation stage, we can identify a patient in this stage of change when they don't see sleep as a problem. So, this is an opportunity where we can plant the seed. We can kind of say, have you noticed your pain flares up after a few bad nights of sleep or a bad night of rest? Or have you noticed that your performance during sport has decreased on nights where maybe you've stayed up to cram for an exam, or perhaps spending all night doom scrolling on your phone prior to like game day, things of that nature. Moving forward, we might catch someone in the contemplation stage. They're kind of weighing all the factors out. So they might come in and say, I feel like sleep has some sort of impact on my performance, on my symptomology. And to kind of like help that along into like the next stage, we can ask reflective questions to kind of help them along that stream of thought. So that next stream of thought is going to be the preparation phase. And this is where we can really start to gain momentum in regard to moving towards creating behavior changes around sleep. So this is where we can think of creating small, realistic steps to start chipping away at creating more habits kind of formed in a chain to prepare for rest. Things like starting with a time away from screens, a perhaps diaphragmatic breathing or yoga type practice, or meditation prior to sleeping, reading for pleasure, not engaging in stressful activity or non-sleep activity in bed, things of that nature, and just like kind of starting with one at a time and adding those up to create an overall change in the sleep quality. And so, when we get folks to be able to take action, which is the next stage in this process, this is where consistency starts to build into this, like, I've got this self-agency that I can take ownership over this. I'm getting some good traction. I can see where this is going in a positive way. And then, the hope is that by post-discharge, they now have this maintenance phase where they can just maintain these habits, hopefully for a lifetime, and continue to build on those in constructive ways. And so when we're thinking about doing all this too, like, we definitely want to think about meeting folks where they are. We can't, take someone who is presenting to us in the pre-contemplative stage and just assume that they're going to take our calls to action and just say, oh, yep, my physical therapist said to do it, I'm going to get on it. It doesn't work that way. This is behavioral psychology 101. We got to meet people where they are and work with them from there. So when helping patients sleep better, it's not about giving them more information again. We've got to meet them where they are, like I was just mentioning. We have to understand where they are in that readiness. Just like with exercise adherence, sleep behavior change moves through these stages. And I like to think of some strategies that we can use. We can borrow from motivational interviewing. So a lot of people have heard of motivational interviewing. but maybe like, well, cool, I know it's good, I know I should do it, but tell me about it. What do I gotta know? So here are some of the highlights, or the greatest hits, if you will, of some motivational interviewing basics in regard to sleep coaching. So PACE is an acronym for partnership, acceptance, compassion, evocation. So this is where we're building collaboration and not necessarily just expecting compliance for the sake of compliance. So here we're looking at guiding as a partnership our patients towards accepting that there's something to change, having compassion for them, knowing that change is difficult, and evoking said change by establishing that collaborative movement. Motivational interviewing also has this nice like flow of engagement, focus, evoking change, creative plan moving forward. We have another acronym, READS, and this is one that kind of reminds us to roll with resistances that are going to be expected with just natural behavioral, psychology that we see in people every day, including ourselves, instead of fighting against folks on it. So we want to roll with their resistance, like I said, express empathy. Avoid argumentation. We don't want to create enemies here. We're not butting heads. We're working together. We want to look at any sort of discrepancies that are here and develop plans for those. We want to support self-efficacy, because we're not just looking at a patient in front of us and treating them in the here and now. We're planning to have them be successful post-discharge, and so we got to think of establishing that self-efficacy. Another acronym that motivational interviewing provides us is OARS, or asking open questions, providing affirmations, reflecting meaningfully, and then providing summaries. So these everyday kind of micro skills can really make patients feel heard, and these are just some of the cheat codes that you can kind of think about, perhaps write on a sticky note and put on your workstation to just kind of help remind you to build a partnership, be empathetic, help people feel heard so that they can move forward with you as a team. So, am I in practice? Just some examples of, some things that we might think about. Again, we're not looking to create these compliant worker bees. We have to ask curious questions. So we can't expect change to happen just because we said you should get more sleep. We have to ask about how does sleep, how does your pain reflect when you get poor sleep or good sleep? Ask these kind of questions. We don't necessarily want to harp on people and jump towards correct. Here's all the things you do wrong. We want to reflect on, what are the barriers, or, man, your whole day as a mom of 3 and you work part-time and you're responsible for all the house workings, it's no wonder you have a hard time mellowing out at the end of the night because you haven't had any time to process anything for yourself. So it's figuring out, how do I help this person decompress before they get to sleep so they're not laying awake straining out their eyelids for an hour. These are curious questions we gotta ask our folks. And, we're not just educating, we're working towards evoking change. So, thinking about what would make better sleep possible for you. Again, looking at those barriers. So, again, kind of want to think about establishing self-efficacy, because it's super important in all regards of our work. I'm super on top of communicating, building small wins. All the time, I'll see home exercise programs or very well-intentioned education be provided to folks where that's just over the top for them. There's no way they're going to be able to comply to this. They can hardly, get a vegetable or fruit in their day. They can hardly, motivate themselves to do more than get dressed and run errands for the day, and here we're going to ask them to do 30 minutes of exercise out of nowhere just because we said so. We got to help them build momentum instead of just thinking of these big grandeur changes. So small wins builds confidence. We got to help them with that. We got to help them see that they can make change. A lot of folks just don't have that agency, feeling like they actually have control over their lives. So instead of dumping all this like sleep hygiene checklists, or, we want to co-create, we want to work as a team. We want to look at one step at a time, and we want to just make like little mini micro goals that are very accomplishable and be collaborative. So as an example, one that I'll often think about or talk about is say like, do you think it would be reasonable to turn your phone off 10 minutes before you go to bed? Typically I say all screens, but phone's a big one. And most folks can say, yeah, I could definitely do that. I was like, okay, pull your phone out right now. Let's set an alarm. What time do you usually go to bed? Around this hour? Okay, well, let's set an alarm for, 10, 15, 20 minutes before then to remind you, all right, phone goes down at this time. We go to bed 10 minutes later. And this is how we kind of get that momentum, make behaviors stick. So moving forward, a health psychology concept that I really like to kind of keep in mind and reflect on, and I use it all the time, particularly when there's just lack of follow through, or just really in general, because I just recognize that when it comes to behavior change, I tell folks all the time it's the hardest but also most rewarding aspect of my job. So I look at this COMT framework. This looks at how does capability, opportunity, motivation work in favor or against behavior change for the individual, and vice versa. How do behaviors influence someone's capability, motivation, and opportunities? So, for instance, capability, does someone have the knowledge or the skills to execute what you're asking of them? If you look at opportunity, does this person are they in an environment that can actually support the change we're looking after? Are they feeling motivated enough? So if we look at the barriers for the individual, that's where we can build strategy and tact in regard to behavior change. So I feel like in today's day and age where we have AI and, before that, and still very relevant, Google search, right? We can get all sorts of generic information and tips and strategies and this and that. And we get inundated with this. So a lot of folks become numb to it. It just becomes empty words or, future opportunities to kind of just fail again. Just another one of those. So I feel like sometimes we can kind of like all this sleep hygiene stuff can kind of get a bad rap, especially if we're just providing generic handouts like a brochure or something. So I feel like just like most things, and it makes sense to me, when we personalize it and we ask these questions, we screen it, and derive, again, curious questions from the screenings, we can match a patient's like routines and triggers to our plan, and it becomes that much more powerful because it's tailored to that person. They feel heard, and it's made for them versus, AI or Dr. Google telling them what's going on. And, things like for chronic pain, we emphasize consistency over perfection. For anxiety folks, we want to emphasize wind down rituals, for instance, when we think about getting like prepared for sleep, what have you, and looking at altering these perceptions of sleep hygiene. And then, lastly on this coaching for behavior change slide, just validating that what someone's experiencing is normal. A lot of patients might feel guilty about their bad sleep habits. We might ask about it and they're like, yeah, I know, I shouldn't keep the TV on when I'm trying to go to sleep, and while I'm sleeping, I know it's a bad habit, and it's probably not helpful for my recovery from surgery. And so it's like, well, where that may be true, like, let's, again, it's like, this person's brain is kind of just doing what it feels like it needs to distract itself to wind down to get to sleep. It's trying to do the best it can. So just kind of acknowledge, like, you're trying to figure things out. And it's great that you recognize that it may not be the most optimal. And now that we have this opportunity to work together to make it better. So I appreciate you bringing that up to me. So let's learn how to do this better together and in a way that works best for you. And that's going to be so much more powerful again than handing a brochure or just saying like, yeah, you're right. That is a pretty awful habit. Maybe don't do that. We can do better. So again, I kind of want to take this moment to reflect. Let's think about one phrase that we could use to motivate our patients. How could we tweak maybe a phrase that we already utilize for perhaps compliance home exercise program, other wellness habits, and think of how we can shift this towards improving sleep habit. So if we look into interventions or treating sleep, again, we're not looking at this as necessarily treating something like insomnia as a diagnosis, but we're addressing sleep as part of the recovery system. So when sleep impacts function, tissue healing, pain modulation, or adherence, again, this is well within our wheelhouse. This is our bread and butter. We got to talk about it. And this is absolutely billable under existing therapeutic codes, and we'll get to that. So, we can reinforce CBT or cognitive behavioral therapy in insomnia principles. So this revolves around things like stimulus control, screen time, consistency, just like with exercises, reduced in-bed wake time. So are we working in bed? Are we scrolling through our phone in bed? All these things that mentally deter us from being able to be in a place mentally where our brain and our system is ready for sleep. And, exercise is great. It remains, according to, when we look at some of the evidence, one of the strongest sleep interventions we can utilize. Aerobic, resistance, mind-body type exercises, these all improve sleep efficiency. Of course, the one thing we should be mindful of is not doing high intensity type work right before bed. Probably, have like a good 2 to 3 hours perhaps of not doing intensive weight training, not doing sprints, not something that really upregulates our system while we're trying to wind down those last couple hours of the night. So something that we know too about sleep is that it has a significant therapeutic effect on pain sensitivity and outcomes, and vice versa. So again, pain, something we deal with or work with, I should say, every single day, and sleep is super important with that. And finally, we can prescribe environmental changes and wind down rituals the same way that we dose movement. We can say like, let's make this specific, consistent, and measurable, just like exercise. All right, so earlier I talked about cognitive behavioral therapy for insomnia. This is like a 5,000 foot view of the whole concept, and you can kind of dive into more of this as far as like the nitty gritty. It's like well established and documented. And we look at this actually as the gold standard for chronic sleep dysfunction regarding insomnia. So when we look at some of the evidence here, it should be the first line for those we identify as having insomnia or with a formal already established diagnosis. Around 75% when we look at some of the literature benefit from this strategy, and 50 to 60% of individuals get faster sleep onset and less time awake, which is going to improve sleep quality, of course. And what's really interesting and a really cool finding is that we see that the effects of this type of intervention outlast the use of medication and supplementation, which is pretty cool. So when we look at some of the core components here of the CBT-I, or cognitive behavioral therapy for insomnia, it starts with a phase of sleep restriction and having a strict schedule. And the reason for this is because we're trying to literally create this predictable start-stop time for sleep so that the system becomes prepared for the landing of sleep time so that we can improve sleep efficiency. So that, we're not necessarily getting this system that enters the bedroom, enters bed, and doesn't know if it's going to be work, scrolling on the phone, or are we actually going to go to sleep. We have to prepare our system, and that involves some sort of sleep restriction oftentimes, especially for more erratic schedules. We want to think of stimulus control. We want to establish bed is for certain activities only: sleep, sex, wind down routines and activities, things that prepare the body. So, if someone's awake for 15 minutes just staring at their eyelids or just busy in thought, get them out of bed, because we don't want to train the body, train the system that bed is just for any old activity. Another thing that we're looking to do during some of this time is avoiding naps, because again, that's going to throw this kind of regularity off in regard to preparing the system for sleep-wake cycles. Sleep hygiene, other things we can talk about: optimizing caffeine, alcohol, nicotine content, or nicotine intake. That's a stimulus, of course, in the environment. Dark, cool environments tend to work better for sleep. Having an evening routine, so the body recognizes patterns. If we always brush our teeth, do some stretches, yoga, breathing, meditation, whatnot, and then go to sleep, hit the pillow, our body starts to learn that. And then it gets to the point where we're brushing our teeth and we're can't open your eye because the body just knows what's coming next. And we're already half asleep by the time we get through our next step in the plan. And speaking of relaxation wind down training, again, this could be things that we talk about anyway for stress reduction, or those with headaches, but this falls right in line with sleep. Breathing strategies, breathing exercises, progressive muscle relaxation, guided imagery, all these are within our wheelhouse to talk about. So the way this is kind of structured out, it's a 6 to 8 week program or so. Most people find a measurable improvements in 4 weeks. So kind of similar to when we use our typical plans of care, like mixes of massage or manual therapy and exercise therapy for many musculoskeletal instances. And we should also set the stage for saying there's going to be, especially in that first phase where we're creating some restriction, that there's going to be 2 to 3 weeks of worsening symptoms because the body's got to make some adjustments. So kind of, I think of this almost like the DOMs of sleep. And, again, setting the stage for this high structured program and being consistent with it leads to these results that overperform when it comes to medication and supplementation even, which is amazing. All right, so documentation. I know this is the bane of everyone's existence, but it is necessary, and especially if we're going to think about utilizing sleep screening and education, and education or intervention speak, we got to make sure that we're backing it up with documentation. So I have a couple examples here with the CPT codes that we can utilize alongside. So for instance, a SmartPhrase that I use, and we use Epic where I work, is under self-care/home management training, or 97535. Educate a patient on sleep routine and environmental strategies to improve next day energy and task performance. Discuss consistency, wind down period, and pacing. And you can word this however you like, of course, and there's many ways that we can go about this for different CPT codes as well. Another example I use is for neuromuscular re-education, or 97112. Discussed how improved sleep supports neural recovery, proprioception during balance training, emphasizes body awareness and fatigue control strategies. These are things, again, that we're talking about all the time anyway. Sleep is right on that list. So writing out goals, because we know we have to have goals that are objective, they're specific, they're measurable. There's a timeline in there. You know, I have a couple short-term goals listed here, long-term goals, so we can make it pertaining to the patient-reported outcome measure, like the PSQI, and kind of back that up with, you know, to improve sleep quality, improving sleep quality, to improve recovery between games and practices, or, you know, look at a nightly 10-minute breathing mobility routine greater than 5 nights per week to reduce time to fall asleep. So again, kind of like building these behavioral strategies to help the body learn to wind down through habituation. Home stretch, folks. So the sleep action build, this is kind of, again, summarizing the whole kit caboodle. This is where it all lands. So sleep shouldn't just be this side piece conversation that just gets a little bit of action. No, this has got to be our main squeeze. It's a part of recovery. It's part of energy regulation, pain modulation, movement performance. Like, this is important stuff. So let's start small, just like we should recommend for a lot of our patients. This week, just ask one sleep question in your eval. Build up from there. Utilize some of these screens. Pick one education line that you could use with every patient. You know, we can say, you know, try to wake up within 30 minutes at the same time every morning. Create these micro goals. You know, let's coach this better. Try using one of the few or handful of motivational interviewing strategies to coach a routine. Drop one micro goal for your patient while you're at it. There's plenty of motivational interviewing techniques that we can utilize, readily available online. You know, we certainly want to document it. We want to measure these things, because if we're collecting data and we're showing functional impact, this is what drives both outcomes and our billing justifications. And I always like to say, if we're not assessing, we're guessing. So, you know, after some weeks, just like with exercise and our other objective measures, let's reassess sleep as well and reutilize these measures. So, you know, again, as a physical therapist, if this affects function, it is ours. So screen, educate, coach, document, measure. Please make sleep more of a priority and bring it to your practice on the daily. Spread this like wildfire across the clinic, across your colleagues. Subscribe on all my socials, please. I'm loving every bit of sharing information to provide to you all. I'm on practically all the socials. NerdyBPT is the handle. Save this, share it, comment, tell me what you love, tell me what you hate, tell me how I was wrong. I would love to interact with you. So please let me know you're out there. Let me know you're listening. And I'll catch you later. Have a great day.